Dr. Asar. So, good evening, all. Today, we have a very special guest with us. He is my near and dear senior from AIMS New Delhi, and he's also from my Rajasthan, India area. And currently, he's working at Toronto, Dr. Nimish Mittal. So, we have welcomed Dr. Nimish Mittal, sir. He is currently working as an assistant professor at Temerty Faculty of Medicine, Department of EMR, University of Toronto. He is also medical director at Good Hope Ehlers-Danlos Syndrome Clinic at Toronto General Hospital. So today he is going to be presenting his lecture and his ideas on advanced therapeutic options for shoulder pain in glenohumeral arthritis and adhesive capsulitis. We will be learning the anatomy and Sono-Anatomy relevant to rotator cuff interval. Along with that, we will be learning about the shoulder joint articular sensory innervation of shoulder joint and ultrasound guided techniques for capsular Hydro-Dilatation and radiofrequency ablation for glenohumeral joint. So we welcome you, Nimish Mittal, sir. So over to you, sir.
Sanjeev, thank you so much. Should I share my slides?
Yeah, please.
Perfect. Can everybody see my slides?
Yes, sir. Yes.
Super. I'm just going to move this icon here. Sanjeev, thank you for the kind introduction. And thank you so much for this opportunity and invitation to come back and talk to colleagues in India. Also, I see some of the colleagues and some of the seniors and teachers of mine who are present here. So very kind gratitude to them. And welcome to everybody for making time on Saturday at 8 o'clock to join us for this presentation. What I'm going to do today is the title of the topic, as Sanjeev mentioned, is Advanced Therapeutic Options for Shoulder Pain. We will discuss two specific conditions, adhesive capsulitis or frozen shoulder, and a glenohumeral arthritis. You know, shoulder pain is the third most common cause of musculoskeletal pain for which any person comes to see a doctor in the office. And most of the physiatrists who are pain physiatrists would see this commonly. The differentials include a rotator cuff pathology, some impingement syndrome, bursitis, or frozen shoulder and arthritis. Now, since this platform is for interventional pain physiatrists, I'm going to focus more around the interventional aspect of the management of these disorders. And for both frozen shoulder and glenohumeral arthritis, there have been, we have known these disorders for more than a century. And until last 10 years, there were management approaches, conservative and interventional, which existed that included, physiotherapy, rest, NSAIDs, cortisone injections, which were landmark-based, and so on. However, in the last 10 years or so, with the advent of musculoskeletal ultrasound and its proliferation in the community, a lot of people using it, also with the anatomical studies which have shown us the articular supply of the joint, we have now been in a place that we can address these both conditions in a better fashion. So what we're going to do today is, as Sanjeev mentioned, and I have to look how to move my slides. Do I get a control of my slides, or would you be running the slides?
You'll be running the slides, sir.
Do I have? Oh, I have a slide control here.
Yes, sir. Yes, sir.
Do I?
You just have to. Oh, it's moving, sir.
Yep. Okay. I'm just going to try and move it, but I don't think I can move it from my cursor, which I would like to do. Can you give me the slide control if possible?
Sir, you are the host. You can move the slides.
I can?
You can move, sir.
On my
Slides
cursor.
are moving, sir. Slides are moving.
Slides are moving, sir. No issues, sir.
They're moving. Yeah, but I can't, I can only go back, but I can't go, okay, perfect. Yeah, that's fine. Perfect.
Yes,
Yeah,
yes, sir.
So, what we're going to do today is we're not going to get into the nitty-gritties and too much details around what frozen shoulder is or what arthritis is. We'll focus this talk on the anatomical details because we want to find out the rationale of anatomy, which is relevant to the interventions that we do. So we will look at the relevant anatomy and the Sono-Anatomy, fluoroscopic anatomy to look at what exactly are we doing. Then we will get into why do we do these interventions, when do we do these interventions, and how do we do these interventions. And in the how, we'll go over both ultrasound and fluoroscopy guided interventions, techniques for doing these procedures. I don't have any disclosures for today's presentation. First, we'll start with frozen shoulder or adhesive capsulitis. We know this is a disorder which causes a synovial inflammation around the glenohumeral joint that results in range of motion deficits and chronic pain. Now, if you would look at this graph, which is on the right side of the image here, there's a natural course of disease involvement and progression of the disease. The disease usually lasts somewhere around 24 to 36 months. And then there's a bell-shaped curve in which the stiffness kind of increases and then gradually goes down, and then it kind of like increases again. The same thing happens for pain. The pain gradually starts, goes to a peak level, and then it comes down again. And the patient is usually suffering for around 24 to 36 months. Since this is a disease which kind of has a spontaneous resolution, a lot of people would used to say in the past, so you could do some physiotherapy and you could take some NSAIDs and that would help you. However, while the patient is going through the disease, there's a lot of effect on their quality of life because of pain and stiffness, the activities of daily living they cannot do, and so on. So it is not rational for them to have to suffer through this time. And in terms of the different treatment options which are available for frozen shoulder, this is a systematic review and network meta-analysis which was published in JAMA in 2020. What they did is they compared every possible randomized controlled trial, which has compared two treatment options for frozen shoulder. And they looked at the relative efficacy or effectiveness of these procedures. They started with approximately 73,299 records. And at the end, they ended up including 34 studies in the meta-analysis with around 2,500 patients. Now, if you look at this image here, I want you to first focus on the left side where you see the dots and the lines. The dots represents the relative number of studies for each intervention, where you see the maximum studies are for intra-articular corticosteroid, and these lines depict the contribution of the comparison between two different interventions. So if you see the broadest line is for corticosteroid versus placebo. And these are the results. This is actually the paired network meta-analysis on the left side. And if you would see the maximum amount of contribution is between corticosteroids and placebo. Beyond that, corticosteroids and subacromial corticosteroid versus intra-articular, and then the corticosteroid and physiotherapy. And mind you, these are the results which we are looking at 8 to 12 weeks of follow-up. Now on the right side of the image, there is this bar graph. On the x-axis, you have all these different treatment options: no treatment, intra-articular corticosteroid, physiotherapy, and arthrographic distension with so on. On the left side is the probability of its effectiveness, going from 0 is the worst and 100 is the best. And as you can see, the maximum efficacy is depicted for arthrographic distension with intra-articular corticosteroid, which is done fluoroscopy in these studies. And the second one is for intra-articular corticosteroids. There's other options: physiotherapy, subacromial, no treatment, but they lie all below intra-articular corticosteroids or arthrographic distension. So one thing we know now is that intra-articular corticosteroids have benefit. However, in the past, we used to give these steroids using a posterior landmark-based approach inside the joint. And the effect only lasts for around 8 to 12 weeks mostly. And it is also not a disease-modifying procedure. After 8 to 12 weeks, the pains would come back, the range of motion would get back to the reduction level where it used to be. And then there's a question about repeated steroids and what they would do when they could cause the damage to the articular cartilage. They could also cause some collagen washout, worsen, kind of like weaken the tendons and so on. So then now there's also another group of cohort of physicians who would say, oh, we are doing very well with these landmark-based steroid injections. So why should we use ultrasound? What is the benefit of using ultrasound? The other thing is people always used to inject these joints from an intra-articular posterior approach. And now in the recent times, there is a new approach in the anterior rotator interval that has been used. So does it matter if we use the posterior approach versus the anterior approach? And then the last question in this is, how much volume should we inject when we do these procedures for a hydrodilation? Is 5 ml okay, or do we need 10 milliliters, or do we need 20 cc's or 40 cc's or 100 cc's, or until the capsule ruptures? So we're going to take a dive into all these questions and try to answer that. Now, first question is, should we do it ultrasound guided or not? So this is an old study published in around 2010 when ultrasound was gaining popularity. And at that point of time, we figured out that we could actually, in this study, they did a randomized controlled trial looking at the difference in efficacy of a blind procedure versus an ultrasound guided procedure. Number of cases were 20 in both of the groups. They randomized them quite properly. Baseline characteristics were very, very similar. And what they found is that if you look at the VAS score on the left side or the y-axis and the weeks on the right axis, blue graph is for ultrasound and red graph is for blinded approach. You could clearly see that ultrasound is more accurate and results in earlier pain relief as compared to the blinded approach. Although at around 6 weeks, you can see this effect kind of gets very similar, which may be related to the systemic effects of cortisone. But from this, we can definitely conclude that it is a better, more accurate procedure that results in earlier resolution of pains, which helps to establish trust and rapport with the patient. Now the pathophysiology, like the question we're going to tackle is anterior versus posterior approach. In the past, we knew that there's synovial proliferation, which affects frozen shoulder. However, in the recent past, there have been multiple MRI studies, cadaveric studies, which have found that it's not only the intra-articular or the synovial recess which is affected, but this area of the shoulder joint called the rotator interval, which lies between the subscapularis and supraspinatus tendon. And there's intracapsular but extrasynovial. I'll repeat it again. So there are certain structures which are inside the capsule or around the capsule, but they are not inside the articular surface, which include the coracohumeral ligament, the superior glenohumeral ligament, the middle glenohumeral ligament. These structures are affected in frozen shoulder because of the inflammation in this area, but they're not inside the articular cartilage. So if you would inject somebody from the posterior aspect, they would only get, the medication would only disperse in the intra-articular aspect. It would not disperse in this pericapsular or intracapsular yet extrasynovial aspect, where these inflamed structures like coracohumeral ligament and superior and middle glenohumeral ligament lie. Injection approaches, we've already said there's a posterior approach, which we use all the time. And now with the use of ultrasound, there's this anterior approach in which we target the rotator interval. And this approach, you could see I'm doing this from the lateral side and not from the, there's one way in which you could bring the needle from the medial side. There's another approach where you could bring the needle from the lateral side. And we're going to get into that in a little bit as well. Now, whether we should do an anterior approach or posterior approach, this question should not be existing in this times, but I often see it on social media and here and there, it still continues to pop up. There are around, now there's 8 randomized controlled trials which have compared anterior rotator interval approach injections versus posterior glenohumeral joint injections, ultrasound guided, all of them. And in them, they have include steroids, different kind of steroids from triamcinolone to methylprednisolone and 40 milligrams only. And they've also used somewhere total volume is around 5 cc's to 20 cc's in all these studies. So the volume is not really more than 20 cc's in any of these studies. And this is the meta-analysis looking at pain relief for 4 weeks, 8 weeks, and 12 weeks. And you can clearly see this forest plot. The 0 marks the midline. If we go on the left side, it is more in favor of the posterior approach. If you go on the right side, it's more in the favor of the rotator interval approach. And you see the diamond here is clearly between all these trials very much in favor of the rotator interval approach for pain at all 3 different time points. Not only that, if you look at this functional improvement for 4 weeks, 8 weeks, and 12 weeks, it shows the similar results. There's only improvement on the right side of the axis in the rotator interval approach. So it's quite clear that because the pathology lies in the anterior rotator interval, which is intracapsular but extrasynovial, on top of being intrasynovial as well, there's better outcomes which happen if this injection is done using an anterior rotator interval approach as compared to the posterior approach. Just a little bit about the pathanatomy in terms of what this anterior rotator interval approach is. You can see the longative biceps tendon makes a 90 degrees turn as it goes proximally and attaches to the glenoid and the labrum. And while doing so, it comes across an intra-articular portion, which on a transverse oblique ultrasound looks something like this here, in which on top of the longitive biceps tendon, there's coracohumeral ligament. On the medial side, it starts with the subscapularis muscle. There's medial part of coracohumeral ligament. Then there's a transverse, kind of like a superior glenohumeral ligament, which pops in. On the lateral side, there's lateral coracohumeral ligament, and the most lateral part is the supraspinatus tendon. On the right side, you see here, it kind of looks like this. Coming back to this left side of the image, now here's the very important part which I really want to focus. This is probably one of the most important critical points in today's presentation. This is an image in which we are looking at this rotator interval from the front, but slightly from the top. So it's a tangential bird's eye view. You look at this yellow layer, this is actually the layer of the capsule. So anything inside this layer is intra-articular, and anything outside this layer is peri-articular or intracapsular, but extra-articular. So you see the coracohumeral ligament. So this is that layer, the yellow layer, and anything which is outside of this, the coracohumeral ligament, the superior glenohumeral ligament here, they're all extra-articular. So if you would make an injection from a posterior approach, it would only flow inside this area. Whereas if we make an injection using an anterior rotator interval approach in this area, there are several permeable spaces between the capsule, which leads to bathing of the coracohumeral ligament, the superior glenohumeral ligament, and the middle glenohumeral ligament that causes a better dispersal of the injected medication and results in better outcomes. This was a study which we conducted I think a couple of years ago. We looked at the staining patterns of injections when we did it using an anterior, like both of these are anterior approaches, but we looked at whether we are doing a medial to lateral injection, if you see on the top left corner, versus if we do a lateral to a medial injection. What we found out in this, we looked at the staining patterns after first we did the injections in these cadavers. There were 5 cadavers we injected, and after that, our group of Ann Auger and John Tran, they dissected them and looked at what exactly did we do and where the staining pattern was happening. What we found was that when we do a medial to lateral injection, sometimes the needle kind of gets stuck around the superior glenohumeral ligament and it does not really flow inside the capsule. So it may result in a pericapsular spread, but often it does not get intra-articular in nature. Whereas if we brought the needle from a lateral to a medial approach, then there was 100% spread on the intrasynovial structures, extrasynovial but intracapsular structures, and also the pericapsular structures such as longitive biceps tendon and so on. So because of that, we changed our practice. Now we don't do any injection using a medial to lateral approach. We only approach it from a lateral to a medial perspective. Because in the medial approach, there was a 60% frequency of staining, but in the lateral approach, there was 100% staining, which we found in all the cadavers that we injected. Other question is, I often see people talk about the volume of injection and whether we should do a capsular rupture or a capsular preservation approach. This is a study published in Skeletal Radiology 2023. They divided patients into 2 different groups. One is the capsular preservation approach, the CP, and the capsular rupture approach. I want you to focus on this graph here. On the left side, it shows the bar diagram with VAS scores. On the right side is the disability dash score. And the purple diagram is for the capsule rupture, and the blue diagram is for the capsule preservation. If you look at the VAS scores, they were kind of like equal on both sides here, whereas as the time went on, there was a significant statistically and clinically meaningful difference between the VAS scores in these rupture and preservation approaches. Both in the VAS scores and also in the dash scores, you would see that higher dash score is suggestive of more disability. So you see the difference in the dash scores between the capsule rupture versus preservation was so high at all times at 1, 3, and 6 months. So it kind of concludes clearly that capsule preservation approach is better than capsule rupture. Now, the other thing is, when you do a capsule rupture with a higher volume, it also shows you that the rupture of the capsule happens at the weaker parts of the capsule, which are the axillary recess, the subscapularis recess, and the bicipital recess. It does not happen at the level where the fibrosis actually is. And I'm just showing you these studies, these results from the study which we just submitted a revision for. And what we did in this study, we had actual patients who had frozen shoulder, and then we injected them with 10 cc's of medication, which included saline, lidocaine, and steroid. And along in the saline, we added some gadolinium contrast. And right after the injection, we took them to MRI. We got this MRI done. with 10 cc's of medication in both in the anterior approach, you could see there's adequate dilatation of the bicipital recess, the subscapularis recess, and on the lower part, not in this image, but the axillary recess was dilated as well. So with 10 cc's, you can get adequate dilatation of all the different recesses in actual patients who have frozen shoulder. So you don't really need anything more than 10 cc's to do a hydrodilation procedure. Now, how do we actually do it? This is an image from a study. There was researchers based in Montreal. What they do is, if you look at how to scan for this rotator interval, on the left side of the image, we start transversely targeting the long end of biceps tendon, and then we start moving cephalad or upwards, and we also start obliquing the probe a little bit. And as we do that, the change of the shape of the biceps tendon or the long end of biceps tendon changes. Now, if you look at the image on the right side here, the image A on the left side corresponds to a kind of like a round biceps tendon, which is sitting very nicely in the intertubercular sulcus or the bicipital groove. And on the right side, there's greater tuberosity, lesser tuberosity. As you go up further, you see that the bicipital groove is gone. You only see the head of the humerus, and the shape of the biceps tendon has changed from a rounded shape to an oblong shape. And that is where you know that you have hit the rotator interval, and this is where you should make an injection for frozen shoulder. If you continue to go further, you'll see that the shape of the biceps tendon changes further, and it comes to sit very close to the articular surface. This is not the place which you should be targeting for a frozen shoulder injection. This is actually the place you should be targeting if you have a labral tear, but we are not covering this as part of this talk today. So for sometime later, maybe. Just to show you how the scan works, right now the probe is kept in the transverse orientation. We are in the bicipital sulcus, the intertubercular groove. You can see the greater tuberosity, the lesser tuberosity. As I scan cephalad or upwards, you can see the biceps tendon here. It's actually perching a little bit on this side, but as soon as we go further higher, oops, how can I freeze it here? Probably doesn't freeze, but yeah, when you continue to go cephalad, you can see that around getting around this area. Now you hit the the rotator interval region. Now, when we make this injection, we come from a lateral to medial side. This is not how we do the injections. I just want to show you the spread pattern in this thing, in this image. And you would see when we start injecting, there's nothing which is happening here, but there's a spread which is coming backwards in this area. This is not how you should make this injection. The needle orientation should also come more at around 12 o'clock or 11 o'clock position as compared to the 2 o'clock position, which I have here. And then what it would really look like is once you have this biceps tendon, this needle, which is sitting right on top of the biceps tendon in this image, and the injectate just flows. If you can see the shimmer, which will happen here, I'll play it again, the shimmer of cortisone, which happens due to the particle in the cortisone. You can see that shimmer. There's no blobbing. There's no lifting of anything. It's just going intra-articular at this space, and we are done. And so what you have to truly do to run this is you have to find a resistance-free margin in this area. You have to bring the needle close to the top of the biceps tendon, and then you might have to move the needle a little bit to find a resistance-free margin. Even in patients who have severely adhered capsules, you can find that resistance-free margin, and that is where you should be making that injection. We usually inject around 7 to 8 cc's in here, and the final 1 to 2 cc's, you see I retract the needle, and I inject around the capsule, and then I come out. So this is how a frozen shoulder injection should be done. Alrighty, that was all I had for frozen shoulder. Now we're going to move to the radiofrequency ablation of shoulder joint. And for this one, let me see how many minutes I'm in. I think time looks okay. So glenohumeral arthritis is also a very common problem, and most of the times we address this as giving cortisone injections. We would give exercises. We would provide some kind of other NSAIDs to the patients, but each of them have their own benefits, pros and cons. In the last 10 years, our group did some excellent work looking at the articular sensory supply, which is not the supply that gives a motor supply to these nerves, but the nerves which are supplying only the sensations to the capsule of the shoulder joint. The earliest work for it, this work is nothing new. It has been done in the past for several centuries, but the modern comprehensive evidence comes from the work of Gardner. In 1948, he published a lot on the articular supply of knees, the shoulders, the hips. But what happened is the game changer was this article by Choi in 2011. They published a randomized controlled trial of doing, which was a sham controlled, double-blinded trial for knee osteoarthritis, and they did RFA of the knees and looked at the comparative outcomes for pain and function, and there was a significant benefit that was shown. Once this trial came out, it triggered the researchers like no other. At that time, ultrasound was getting involved as well. So around this time, after that, within the next 10 years, now there's around 100 studies which are published on mostly on knees, a little bit on hips, and just a little bit now we're coming to place in shoulder. We kind of compiled this evidence for shoulder. Our group did this again in 2021. And in the past, people would do a suprascapular nerve block using a steroid and local anesthetic, which would provide patients relief of around 3 months. Now, some of the more aggressive people went in and they also did a radiofrequency ablation of the suprascapular nerve, but it resulted in motor weakness, as we all know, being physiatrists and pain physicians, that this is not something that we should be doing because it results in weakness of the motor supply of the shoulder joint. Actually, American Academy of Orthopedic Surgeons issued a white paper statement saying that this is not recommended and should not be done. That was the experience. The other thing was, like, previous understanding was that suprascapular nerve supplies 70% of the innervation of the shoulder joint, but that was really not true. Now, this is a study by Lemuir they published, and they looked at what are the structures in the shoulder that are innervated and what are the nerves which innervate that shoulder. So the structures which are innervated include the capsule, the anterior capsule, the posterior capsule, subacromial bursa, subdeltoid bursa, longet of biceps tendon, and AC joint. And these are the 4 nerves, including axillary, suprascapular, lower subscapular, and upper lateral pectoral nerve, which innervate these joints. And this is an image which actually shows what's going on here. If you look at the left side of the image, this is the anterior part of the shoulder. The area of green is actually high to low density of mechanoceptors, but the red area is where the actual density lies. So you see the longet of biceps tendon, the subacromial, the joint capsule, the AC joint are the areas which are really innervated richly by mechanoceptors and nociceptors as well. Now, we're going to address all these 4 different nerves and see how and where they branch and supply to different parts of the shoulder joint. If you see this is a suprascapular nerve, we're looking at it from a bird's eye upwards approach. It comes in the suprascapular notch. From the suprascapular notch, it lies in the suprascapular fossa, and then here through the spinoglenoid notch, it comes down. But you also see it kind of supplies a branch around here on the lateral side, and there's also a branch which goes down here on the infralateral side as well. So we're going to take a look at a little bit around those branches. So this was again a study which was published by Philip Peng, John Tran, and Auger, and they looked at the articular supply of the suprascapular nerves. In suprascapular nerve, there's 3 specific branches that we target when we do a radiofrequency ablation. Now, on the left side of the image, this is an anatomical image. We are looking at the scapula from the back. So if you would see, this area is the fossa, the suprascapular fossa. And here you see there's one branch which is the acromial branch of the suprascapular nerve. It supplies the subacromial bursa. It supplies the acromioclavicular joint, the light blue. And then there's another branch which comes downwards here, which is called the superior articular branch. Now, the right side of image is focused mostly around the infraspinatus below the spinoglenoid notch. So this is the spinoglenoid notch around here. And from the spinoglenoid notch, there's an articular branch which comes out laterally, and it supplies the shoulder joint, the posterior part of the shoulder joint, which is, again, the infralateral branch of the articular branch of the suprascapular nerve. Axillary nerve is quite interesting because if I want you to focus on the right side of the image here, axillary nerves comes out of the posterior cord of the brachial plexus, and then it comes to lie on top of subscapularis, but it has an angular course. It goes downwards, and once it reaches the inferior border of subscapularis, then takes an angular course, dives down dorsally, and then it comes down posteriorly around here on the left side of the image, and then it supplies it has 2 different trunks, and then one of the trunks supplies this capsular branch around here. But one thing which is important about axillary nerve is that this axillary trunk, main trunk of the axillary nerve, also supplies a lot of articular branches to the shoulder joint. If you look at this, this is a work from Gardner, and he actually showed that uh, axillary nerve not only supplies posteriorly to the shoulder joint, but it has a bunch of anterior branches which are supplying the capsule of the joint. They go to the subacromial bursa, and then they also go to the, so here they would go to the articular surface, subacromial branch. They would supply the long of biceps and the shoulder joint capsule as well. So this is how and where we actually target our axillary nerve for RFA, and not really the posterior branches, because a lot of researchers have shown that you would target the axillary nerve around the posterior branch, but by that time, most of the anterior supply and the posterior inferior supply has gone. So if you target it around the capsule posteriorly, a lot of the articular supply has already gone and you've missed that. Lateral pectoral nerves comes out of the lateral cord. It kind of crosses the axillary artery in the supraclavicular area. And then after that, it comes down in the clavipectoral fascia and then dives down into the pectoralis major, where it supplies the pec major. However, around before in the around the suprascapular area, it also provides a branch. There's a branch which comes out, goes laterally, crossing the coracoid and lying between the coracoid and the clavicle, which is the articular branch. It lies deep under the clavipectoral fascia, which is the true articular branch of the lateral pectoral nerve. Now, we've also seen a bunch of researchers who would do lateral pectoral articular shoulder block in the which is kind of in the pectoralis major. That is a motor nerve supply and is not truly the articular branch. The articular branch, if you would see, is the green branch, which kind of lives around here, goes anteriorly. The pectoralis major lies downwards. This is not where it's targeted. The other one is the subscapular branch. It kind of runs again in the posterior cord, and then it comes out, lies on top of the subscapularis. But there's an articular branch which comes out of it, one or two articular branches which pierce the subscapularis, go deep and supply the articular surface. As I was saying before, the area of targeting for lateral pectoral nerve articular branch for shoulder denervation should not be in the pec region. It should be higher up in this clavipectoral area. Indications are arthritis, avascular necrosis, rotator cuff arthropathy, for which you can do these procedures. Now, we do it using a two-step approach. First, we do in office, when we see a patient who has shoulder arthritis and they failed other interventions, we will do a diagnostic block first. And in the diagnostic block, we actually block the motor part of the suprascapular nerve, and we also do a diagnostic block of the lateral pectoral nerve. The reason why we do them is because they can be easily targeted using an ultrasound approach. But when we do the actual burning RFA, we would use a combined fluoroscopy and ultrasound approach. For the three branches of suprascapular nerve, we ablate them using ultrasound. The lateral pectoral nerve, we ablate using ultrasound. And then for the axillary and the subscapular nerve, we use fluoroscopy. Now, one other thing which we do is we don't use the routine conventional radiofrequency tips for these ablations, because the ablation on the regular conventional tips happens along the shaft, and you're entering these nerves perpendicularly and coaxially, so you would only get a small lesion. So what we use is we use these Trident needles, which have a larger lesion, and you can insert them coaxially and still get a better burn around. So it's quite important to be aware of this. For suprascapular nerve, I'm not going into details of positioning. It's well published how the suprascapular nerve block is done. I'm going to just show you quickly on how we approach it. So this is a view transverse. On the left side, you can see the probe is kept. You can see part of the glenoid. You're in the suprascapular fossa. But it's important to know where exactly in the fossa to inject. And so what we do is we first go into the fossa, and then we start scanning cephalad. And when we start going cephalad, you see now the bony continuity of this suprascapular bone is, the scapula is broken. So I'll come back again here. You see that the bony continuity of scapula is maintained. And as I'm translating anteriorly, now you see the bony continuity is gone. This is also here, you can see the vascular pulsations of suprascapular artery. So this is the suprascapular notch. If you go around here, you cause pneumothorax, or you can puncture the lung or go into a bad zone. You don't want to do that. What we do after going here is that you again start translating the probe posteriorly or backwards, and then you start coming to a place where you would again get this, oops. You'll again, so if I come around here, you can see you'll again get to a place where you see the entire body of scapula. As soon as you start drifting posteriorly or downwards and you see the entire bone of scapula, that is where you should be making this injection for the diagnostic block. Again, another small part about the diagnostic block. I want to show you first the image of the video on the left, then the video on the right. On the left, you will see once I hit this here, what I do is the injectate which is going out, it is actually going in this pattern. It is going in the muscle. It's not actually truly flowing around the fascial plane. So the nerve usually lies deeper to the supra and infraspinatus, and it actually lies in the fascial plane between the bone and the muscle. If you're having your injectorate spread in the muscle, that is not how the true area of the muscle is, the nerve is. And so again, if I play here, once I hit the needle in the corner, the injectate is spreading mostly around the muscle. So what I do is I then rotate my bevel, again, stick it in the on the bone, rotate it again just to in an attempt to puncture that fascial plane. And then after that, when I make an injection, you see it flows now around the fascial plane here. So it should not be blobbing in the muscle, but it should be going in the fascial plane here. And you can see how the fascial plane then distends and comes up. For lateral pectoral nerve, the way of scanning is we first put our probe where you see the ultrasound image of the coracoid and you see the acromion. And from here, you pivot your probe while keeping the medial border on the coracoid, but instead of acromion, you start pivoting and you come to the clavicle. And this is the end image that you find is the coracoid, the clavicle. This is the clavipectoral fascia. On top would be deltoid. And here you will see somewhere in this middle plane here, you'll see the acromial vessels. And by the side of acromial vessels would be where the lateral pectoral nerve lies. Mind you, this is very superficial or anterior to coraco-clavicular ligaments. Coraco-clavicular ligaments lie quite deep inside. You don't have to go that far deep in for this branch. This is the usual position that we have. This is the anterior side, and we come in from a posterior side to an anterior side. I think I might have a video of this too. Oh, here's the scanning video. You see on this side here is the one side is the coracoid. You see the coracoacromial ligament, and on the other side here is the acromion. Now, when I start scanning, what I do is I'll lose this acromion. Now I'm going medially, and you start seeing this higher bump of the clavicle, which comes in here. And you can see this dot here, which is the acromial branch of the thoracoacromial vessel. The nerve is lying right next to it. So for an RFA or for doing a diagnostic block, this is how we do it. We also did another confirmatory study to look at whether doing an ultrasound-based approach, are we actually hitting the nerve appropriately or not? Again, we used 5 different specimens. We first, under ultrasound, these cadavers, we injected them on the basis of the landmarks that we know based on Sono-Anatomy. And then other group of people, John and they went in, and then they looked at if we stay in the right structures or not. And we had 100% success rate for suprascapular and the lateral pectoral nerve. I think I've already shown you these views. Now, when we do actually RFA, we actually target this acromial branch top up here. We target the superior glenohumeral joint branch here, and then the inferior glenohumeral joint branch here. So we're not targeting the suprascapular nerve motor when we do RF. When we do RF, we are only targeting these structures, and the lateral position is how we keep it. This is not true. We're going to put our probe on the posterior side, but in a lateral decumbent position. I'm going to show you how the structures actually look like. Excuse me. So here, this is the scapular shadow, the spine of scapula, and on top here on the right side is the acromion. And what we would do is we'll keep scanning our probe cephalad until we find this bright shadow to the most highest position in this plane. And this is, at this point around here, is the highest point of the shadow that you would see. This is the target for the acromial branch of the suprascapular nerve. So we're not targeting the suprascapular nerve. And this target plane is even higher as compared to the subscapular notch. So this is the plane where we target for the subacromial branch of the suprascapular nerve. The second one I want to show you is the superior glenohumeral branch. Again, if you were to do a suprascapular nerve block, we would make an injection around here. But when we do an articular RFA, we go far on the glenoid. This is the superior glenohumeral joint branch. And the way we scan for it is you got to bring your probe, like usually how you would do for the suprascapular approach. And then I'll show you here. This is this is kind of the area where we would bring our needle tip in to do a lesion or a burn. This is the infromedial approach. You can see the spinal glenoid notch here, and we'll target far down on the glenoid here. You should not go in the capsular cavity, otherwise you can cause capsulitis. Just stay on the glenoid as far lateral as you can for this inferior glenohumeral joint branch. So those are the two branches I showed, the suprascapular nerve, the lateral pectoral nerve. We haven't yet figured out how to do it, these subscapular nerve and axillary nerve using an ultrasound approach. So we use fluoroscopy for that. What we do is we brought the subscapular nerve anteriorly in the superior 1/3 of the joint and the axillary nerve, the articular branches of the axillary nerve in the inferior 1/3. We can do it two different ways. Fluoroscopy, what you have to do is there's different positionings that have been shown. What you have to mostly do for these is you have to give around 10 degrees of cephalad tilt, around 10 to 15 degrees of ipsilateral oblique for them to have a true glenohumeral joint view. And this is how the lesion that we do. In this image, that what you'll see is you'll see the coracoid here. This is the upper lateral border of coracoid. And this is kind of like a thumbs down kind of a view if you would look put on it here. So you can see the coracoid around here. This is the glenoid. So don't go medial to the glenoid bone. Try to stay like 1 centimeters medial. Don't go, lateral to the glenoid bone. Try to stay 1 centimeters lateral. This is the lesion that we make for the subscapular nerve. And this is the lesion in the lower 1/3, which we make for the axillary nerve. We can also sometimes do a strip lesion if we need, but this is the approach that we use. Now, there's also a complete fluoro approach that has been advised by Max Ackman and Amit Nagpal and their group. What they do in that is this patient lying on the posterior approach. First, they're doing the suprascapular nerve and the axillary nerve. In that, what they do is they make the patient lie down prone with the palm is facing the ceiling like this way, going upwards. And then they would again give around 15 degrees caudal, 30 to 45 degrees lateral, so that the coracoid, instead of staying here, it comes to lie on this border. And then right on the upper lateral border of coracoid, medial to glenoid, they will make like 3 or 4 lesions going from top to bottom for suprascapular nerve. For the subacromial, for the anterior subscapular and lateral pectoral. The D here is for lateral pectoral for them. C here for them is the upper subscapular. Again, they get a thumbs down view, but then they try and put it more in the center of that coracoid versus for the lateral pectoral, they would do in this zone here. So that is kind of an alternate floor approach. Now there's 3 different studies. One, this was published initially by Philip and Agnes, looking at the cryoanalgesia approach for doing this ablation based on the technique that we have described, ultrasound based. And you can see going up to even 12 months, there was a significant difference in the pain scorings of 5 different, other than the one patient which did not show benefit, the 4 other patients had significant benefit lasting to around 12 months as well. We have submitted another study looking at our outcomes. There's another study which I'm reviewing, and they've also shown those outcomes. So the effects are very promising. In our clinical experience, the effects last somewhere between 6 to 12 months, which is better than 4 to 8 weeks effects that you get with steroids. And I'm talking about not the grade 1 or 2 osteoarthritis. I'm talking about grade 3, grade 4 osteoarthritis, even Milwaukee shoulder. If you get the effects are really good for this procedure. I think that's the end of my presentation. Sorry if I took a little bit longer. Happy to answer any questions anybody has.
Sir, excellent presentation. It was a really mesmerizing and enlightening presentation for all of us. Many of my queries, which I was thinking before the presentation to ask you, they were already answered in great detail by you. So thank you very much, sir. So now over to the questions. Anyone has any questions, so please message on the chat box.
Yeah, and one thing I would say is,
Yeah.
don't be afraid to ask any question. And there might be a question which might make us think and do some other stuff, and we might be wrong in doing some things. And I would love to hear from everybody their experience. And if you feel comfortable in Hindi, so we will talk in Hindi. कोई हिंदी में पूछो या इंग्लिश में पूछो, जो भी सवाल है पूछो, और कोई सवाल गलत नहीं है, सब सवाल बढ़िया सवाल है.
So Dr. Aditi Yadav is, sir, can you please close your presentation so we can see your face, sir?
Okay, so I'm going to stop sharing, right?
Yeah, stop sharing. Yeah, this is good. So Dr. Aditi Yadav is asking, sir, is there any role of SASD, bursa, hydrodissection in frozen shoulder?
Yeah, great question. So there are some studies which have, if you remember one of the slides from the JAMA study, which I showed, there is few studies which have looked at subacromial, subdeltoid bursa injections and distension. So there is a role because there's inflammation which happens in that area. But the question then becomes is that is only targeting one, like maybe 15 to 20% of the actual pathology. So why would, like in my logical assumption, why would I target 20% when I can target the 100% of the structure? So based on that, I usually would do a rotator interval injection and not do a subacromial subdeltoid hydrodissection. However, if you want to do that, you'll get some benefit definitely.
Do you use only cortisone, or have you tried some this hydrodilation of shoulder joint with PRP in cases of partial rotator cuff tear associated frozen shoulder cases?
Yeah, so I'm not a big fan of PRP, to be honest, because I've not seen a lot of literature which is compelling, and even in my experience as well, although my experience is very limited, I have with PRP, so I've not seen very compelling evidence. The other thing why we don't use PRP here in Canada is PRP costs around $800 to $1,000 for a single injection, whereas steroids are free. The outcomes of both of them are very similar. If at all, PRP is not better, it could be similar. So then why would we ask a patient to pay $1,000 when we could treat them, give them similar outcomes as compared to PRP using a steroid with a single dose? We're not talking about multiple doses. However, if there's places where PRP is not that, if the cost of steroid injection, like different domains, like in US, it works in a different way, India works in a different way, the how you bill for it and how you get paid. In those instances, then there's a question about having lesser of the evil, then steroid probably is a bigger evil as compared to PRP. Now, the other thing also I want to answer here is PRP has shown no regenerative ability, and now we are beyond that. It's some of the studies focused by the very specific groups who would show regenerative properties, but they have anti-inflammatory analgesic properties on the cytokines and inflammatory mediators, but there's not really any regeneration truly which happens with platelet-rich plasma, based on my understanding from the literature that I have read, and people might have different opinion on that.
Next question is from Dr. Ankit Kumar. Which approach of shoulder joint injection is best, medial or lateral? Blind method versus USG guided in both scenarios. So I think Dr. Nimish Mittal has already answered that lateral to medial is better. If you deposit our medicine or drug is in the between the LH long head of basis tendon and the Schuter's carpus. And the blind method versus ultrasound guided already Dr. Nimish Mittal has already answered. Any other comments, sir?
Yeah, no, as I said, and it is not something which I say is how you do. This is what the evidence says. There's evidence that ultrasound-based approach is better than the blind approach. And then we did our study ourselves looking at from a lateral to a medial approach, which showed better staining patterns and outcomes as compared to the medial to lateral approach. So we use an anterior lateral to medial approach now. We don't use a posterior approach or a blind approach. And just think about it yourself. If you look at other literature for ultrasound versus blind in shoulder joints, there's a 80% chance of accuracy with blind approach and 100% chance with ultrasound approach. So 1 in every 6 injections that you do may not have, using a blind approach, may not have going in the right space. Now think about it. If your family goes to get an injection and there's an option to get an ultrasound-based injection, would you still do a blind injection knowing that 1 out of 6, there's a 20% chance that it may not hit the area where it's supposed to be? So we look at it from that perspective. Now, if you don't have access to ultrasound, that's a different issue. Then you're scarce on your resources, and you have to actually do it using a blind approach. But if you have access to ultrasound, definitely that is the way that you should do.
Okay. Dr. Aradhana Shukla is asking, sir, if we are short of logistics and then we are left with ultrasound guided procedure, what will be you best suggest for one sitting periarthritis shoulder intervention, feeling and conservative level? So exactly what you're asking, I'm not able to understand, Dr. Aradhana.
Really sure. Yeah. I mean, like, are you saying that we have access to ultrasound or we don't have access to ultrasound?
Dr. Aradhana, can you please unmute yourself and you can ask by yourself?
Yes, I want to ask. Hello. Good evening,
Yeah.
sir. On my side,
Hi.
good evening only. I just wanted to ask, sir, you have told a lot of procedures that can be done through ultrasound guided sitting, right? And you do some procedures in which you combine USG as well as fluoroscopy. For
Yeah.
me, if fluoroscopy is out of question and I need to do only ultrasound guided procedure,
Yeah.
what things I should target, and in one sitting, what max I should go for?
And
In cases of
rather, just to clarify that question, are you talking about frozen shoulder or are you talking about the
Yes. A frozen shoulder only, PA shoulder, which is failing on conservative management.
So in frozen shoulder, we don't need fluoroscopy. We never do fluoroscopy in frozen shoulder. The only single intervention that we usually do for frozen shoulder is an ultrasound guided anterior rotator interval injection using a lateral to medial approach. We inject around 10 cc's of medication, which contains 40 or 80 milligrams of dipomedrol, 5 cc's of saline, and 4 cc's of 1% lidocaine. That is what we use. We're also currently doing another study looking at whether 20, 40, 80 makes more sense. But currently,
Sir, one more. Thank you, sir. One more thing. We are actually getting on this path that occasionally we are also adding up suprascapular nerve block for the PA shoulder also. So would you
Yeah.
suggest that combining with hydrodilation, we should be going for it, or we should be only sticking with the hydrodilation and intraarticular steroids?
That's a great question. Nobody has really looked at whether, like, there are studies which have compared suprascapular nerve block with hydrodilation and cortisone injections, but all those articular approaches were done using a posterior approach. There's no study which looks at whether adding a suprascapular nerve block or doing suprascapular nerve block versus an anterior rotator interval injection, and if it leads to additive outcomes or suprascapular nerve block is better or not. So I don't know in terms of research what it would do, but in terms of my personal experience, I can tell you, normally when we do a first injection, we don't do a suprascapular nerve block, because in a person who is otherwise healthy and has primary periarthritis or frozen shoulder, hydrodilation does the trick. They usually get to they may not get 180 degrees of range of motion, but they come into a functional range of around 130, 40 for both abduction and forward flexion, which is required. And then after that, most of the patients choose to just do some exercises and some other stuff. Like in my personal experience, I have found that often diabetics, they would come back for a second shot because in their case, they may not get to a higher functional range. And only in those patients when there's an element of significant sensitization of the shoulder joint, when we do a second injection in diabetics, we add a suprascapular nerve block just to give them a better chance of getting better. But otherwise, normally, we do not add suprascapular nerve block in any other condition or situation.
Thank you. Thank you so much, sir. Thank you.
Okay, sir. Next question was in the same line that in diabetic patients, so what dose of cortisone will we be using, and how many sittings do you prefer in that cases, or what are the other treatment options in cases of diabetic patients?
Yeah, so I think we already spoke about it in the last question, most of it. But in diabetic patients, so in our regular practice, if it is a non-diabetic patient, we use 80 milligrams, 1 cc of dipomedrol. If it is a diabetic patient, then we change it to 40. Now, we don't really know if even in a normal patient, we should only inject 40 because there's no study which suggests so anteriorly. For the suprascapular nerve block, as I mentioned, I add in the first instance, we only see patient for a single injection. We don't see them for 3 months. After the hydrodilation, we give them an exercise sheet to do some specific stretching and strengthening exercises. Specifically, excuse me, the stick-based exercises where they could use one hand to guide the stick and do some stretching is very helpful. So they would do that. And we see them after 3 months. Most of the patients, we don't require second injection. If they have diabetes, they may require second injection. And depending on how much relief or benefit they got from the first, we decide to add on the suprascapular nerve block. That is what our practice is.
Okay, sir. So one of the viewer has asked the most preferred position for anterior approach. So that has already been answered. So,
Yeah.
and next question, sir, line of treatment based on severity, any protocol? So already, I think you have already answered that you are following the patient for next 3 months, doing the rehabilitation protocol, and then accordingly, if needed, then you can repeat the same injection. Next question by Dr. Praveen Gupta.
One thing, Sanjeev,
Yes, sir.
sorry to interrupt. One thing I would say, what we have found with this, with the anterior approach hydrodilation, and I also want to answer another question which was there. Just to clarify, we don't do any radiofrequency ablation for frozen shoulder. That was a procedure I was showing you for glenohumeral arthritis. We do not do any RFA for frozen shoulder. It's not required.
No, sir.
All you have to
Absolutely true, sir.
do, yeah, all you have to do is 1 or 2 injections. One is what we do first. We wait for 3 months, usually gets better with exercise. It doesn't get better. We do second one, maybe we'll add a suprascapular nerve block. The other thing is, Sanjeev, your question was, sorry, I forgot.
So line of treatment based on any severity of frozen shoulder,
Yeah,
any
here.
protocol.
Yeah,
Yeah.
so, we would, this procedure that we do, hydrodilation, it is a disease modifying procedure. Usually the disease, if you do a posterior approach, you give conservative management, NSAIDs, physiotherapy, they would not change the duration of the disease. The duration of the disease would remain from like around 18 months to 36 months. And then during that time, they will be struggling with pain. They have to take a lot of NSAIDs, or they have to do exercises, which they can't because there's a lot of pain. So we do it for, we don't worry about whether it's the freezing stage, the frozen stage, or the thawing stage. Whenever the patient comes to us, if they have frozen shoulder, if they have pain, if there's mild restriction of range of motion, and we are sure it's a frozen shoulder, of course, then we would just do this injection, because then it reduces the whole disease, the natural progression of the disease to around 6 months from the time you're intervening. So why would you, in our philosophy, why would we let patients continue to struggle and suffer with exercises and with medications when there's an intervention we can do which can affect their quality of life? They can sleep better, they can work, go back to their work. And so that's why we intervene at all different stages, and we don't worry about the severity till the time it's a frozen shoulder, and if the patient is willing, we will intervene.
Okay, thank you, sir. So Dr. Praveen Gupta is asking about the volume required. So already it has been answered that 8 to 10 ml is sufficient, and capsule preservation strategy is better than capsule rupture strategy.
Yeah.
Dr. Srinivas is asking about opinion of user of Hydro-Dilatation in treating frozen shoulder. Do you use that Hydro-Dilatation?
We don't use any kind of hyaluronic acid or hyaluronidase for any of these interventions.
Okay. So, sir, should we will not use the posterior approach, or if there is any specific indication for posterior approach? So, do you use any posterior approach anywhere nowadays, or you use only anti approach only?
So for frozen shoulder, we only
Yeah.
use anti approach. And for glenohumeral arthritis, if it is like a stage 1 or stage 2, when the patient is not ready for RF, then we would do a posterior glenohumeral joint injection. And if it is a grade 1 osteoarthritis, grade 2, they have mild clicks and crevitus, you do a shot, give them some exercises, then they get to a better place, and you don't see them for a year or 2. But if it's a grade 3, grade 4, first approach for glenohumeral arthritis, we still do a steroid injection. If the steroid injection works for less than 3 months, then we move on to RFA.
Okay. Dr. Sina is asking, we see in literature that to wait with conservative management before injecting, but shouldn't steroid injection be given in the first stage itself to prevent disability?
That's correct. If you're asking that for frozen shoulder,
freezing stage, I think. Sure, frozen shoulder.
of course, we should. And the other thing is, a lot of people would say, well, they can exercise and continue to maintain their range of motion. The steroid is not a cure, maybe, although it is disease modifying, and I think it changes the duration of disease, but it also enables the patient to do the exercises because their pain is less, they can exercise better, and they can stretch it better. So I think they should be offered steroid without waiting for conservative management.
Any research study regarding the oral steroid versus intra-articular?
Yeah,
some orthopedicians give oral steroids in these cases. So
yeah, there's No, there's, I did not have time. Otherwise, I could show you all different kinds of data on it. Oral corticosteroids have more side effects as compared to the effects. Like when you do these focal steroids, which are local deposition, there's a 2 to 5% systemic absorption which happens. But when you give them oral steroids, they go all systematically, and systemically they cause more damage as compared to the benefits. So it is not an advisable strategy. And there was a systematic review and meta-analysis which was published, I think 2-3 years ago, on the role of oral corticosteroids in frozen shoulder. If you Google role of oral corticosteroids in frozen shoulder, PubMed, last 5 years something, you'll find it.
So Dr. Soni is asking, sir, for how long the physiotherapy should continue post-shoulder hydrodilation?
They can, it depends on the stage and the severity of the restriction of range of motion. What we tell patients is they should do an active exercise-based physical therapy. It does not have to be supervised. They can do it at home. We give them nowadays, in this age of internet and all, we have specific videos, we have specific exercise handouts, which are nurse reviews with them. And then we let them go and then we let them do on their own. We don't want them to spend money on physiotherapy because here physiotherapy is also very expensive. So I don't think, maybe they would need 1 or 2 sessions of supervised physiotherapy, but after that they can learn and do it on your own. And depending on how the progression goes for them, people might need physiotherapy for different periods of time, but they're doing it at home. It's kind of like we go into gym, so they can do 3 to 5 days of stretching exercises until they feel better.
We also follow the same. We used to give a home exercise program to the patients, but in cases, or in some cases, we ask the patient to come once or twice a week for just supervision of the exercises and to give some little bit mobilization on some assisted stretching. So
Yeah.
this is the same thing which we follow here.
That is correct.
So what is your approach in case of hemiplegic shoulder pain with subluxation with capsulitis with full shoulder? I think so.
That's a very low question. Okay, so it's a totally different disease, hemiplegic shoulder pain. And as you have mentioned, whosoever asked this question, as they said, there's subluxation in it. There's mostly spasticity, which comes along with it. And then there's frozen shoulder or capsulitis, which develops with it. So we target the frozen shoulder part of it using the hydrodilation approach. For spasticity, like, as you would do for spasticity, we target, you can either do a cryoablation, you can do a Botox, you can also do a suprascapular nerve block for some of the central pain they might be experiencing. And we also give them a brace so that to prevent the subluxation, because subluxation causes the mechanical stretch on the capsule of the joint, which is nociceptive in nature. So you have to also give them a brace so that subluxation does not happen. And continue to rehab after. We also let them know that the goal of this procedure is mostly pain alleviation, and they're not going to get much of their functional range back because the functional range might be related to their recovery or the weakness secondary to the stroke or the hemiplegia. So there's some kind of expectation setting along that line too.
So any role of continuous brachioplexus block? I think the continuous catheter placement of the brachioplexus and then giving.
And is that for frozen shoulder or is that for?
I think usually this technique is being followed by some pain physicians in which they place a catheter over the brachioplexus area and then they mobilize the shoulder with that after that area.
Yeah.
So for a few days, 5 to 10 days.
Yeah, so a simple analogy to explain it is, if I can kill somebody with my revolver, why would I take out my bazooka? Right? Doing a hydrodilation office-based procedure takes 5 minutes, so easy to do. Patient goes home. Why would you do a more invasive procedure with a continuous brachial plexus block for 5 to 10 days or whatever duration that is, increasing the risk of infection, and would probably have similar or less beneficial outcomes as compared to a 5 minutes hydrodilation procedure? So you could skin the cat in several different ways. I would say we should skin it the easiest and the most convenient, comfortable way, and which is least problematic to the patient.
So how do you deal with the partial rotator cuff tear, partial supraspinatus or subscapularis tear in cases of associated in cases of frozen shoulder. So how do you deal with after the hydrodilation procedure? Do you
Yeah,
give PRP or do you along with the rehab? What do you do?
that's a very good question. The way we address it is, if a person has frozen shoulder, at that point of stage, we don't worry about anything else, which is comorbid association on a structural damage. Once they have a frozen shoulder, think of it as like layers of onion. So frozen shoulder is the first layer that we have to break. Once we break that layer, and then patient still continues to have pains, and if you feel clinically that frozen shoulder is resolved, but the residual pain is because of a tendinopathy or a shoulder dysfunction or a shoulder impingement, then you address it accordingly as you would do for any other situation. However, if I were to do an MRI of 1,000 shoulders, around 950 of those shoulders, in around, let's say in 40 to 60 years of patients, I would do an MRI of 1,000 people, 950 people would show some kind of a tear. And only 50 of those would have pain. So having a structural abnormality does not mean that it is a pain generator. So you have to use your clinical acumen, find out if there's truly a pain generator, which is a residual part of frozen shoulder, or is it truly the tear causing a nociceptive signal to the brain, and then you treat it accordingly.
Okay, sir. Sir, I routinely do this anterior approach rotator cuff hydrodilation procedure. So, but I find that it is difficult to inject it with a 26 gauge needle.
Oh,
So,
yeah.
what gauge basically do you prefer of needle do you prefer while injecting, and what should be the needle should be pointing, bevel should be pointing upwards or downwards when you place it in at the 11 or 12 o'clock position of the biceps tendon?
And who's this person asking the question? Is a brilliant question.
So it is me, I am myself is asking.
Okay, all right. Okay, all right. Yeah. So I was going to say it's a brilliant question because it tells you that the person knows what they're doing and how and where they're doing any stuff there. So Sanjeev, 26 gauge does not generate enough pressure to deposit the medication. So you are right. If you use anything beyond 25, 26, it will be very hard to inject that medication. We commonly use a 21 or a 22 gauge needle. So with that, because the gauge is bigger, the volume which comes out is higher, it creates more pressure and it's easier to inject. Your second question about bevel up or bevel down, what we do in our practice is we start with a bevel up. The reason we start with a bevel up is because you can see the nice shadow of the bevel, and you'll see a very nice ultrasound shadow of the bevel because the ultrasound beam cuts across and it reflects it quite nicely. Once we reach our final target, then we rotate the syringe by 180 degrees, and then the bevel comes down, and then we inject.
So I think all the questions, some questions like regarding the prolotherapy versus steroids or PRP versus steroids already has been answered. And what books do you recommend for interventional pain management? So any one or two books?
That's a great question. I have not looked at so many books in the last several years, so I might not be the best person to advise on any specific books. And I'm sure if you Google, you'll find out a lot of different books.
Yeah, definitely, sir, definitely.
Right?
Any promising regenerative medicine intervention coming up for arthritis?
Novel, not that I know of. It is, and as I mentioned before, we get such an excellent result from this hydrodilation procedure, single sitting, that we would not be looking for something. If something is working, why to go out and look for something more aggressive? You do a single intervention, it helps, and it's a single steroid injection is not too detrimental. Also, any regenerative medicine stuff is not covered in the social healthcare system here in Canada. So we're not looking out for it, but and I don't know anything which exists.
I would like to answer Dr. Naufal question. He's asking that in case of shoulder arthritis. So Naufal, in shoulder arthritis.
Okay. Got you. So that's again a great question. There are studies which people are looking at doing some intraosseous interventions that might pan out to something, but it's very, very early.
I would like to answer this question. I routinely use PRP in cases of shoulder arthritis, degenerative shoulder arthritis. So I either by anti approach or either by posterior approach, I deposit my medicine within the capsule of the shoulder joint, and I find that after doing this PRP or growth factor concentrate, the patient get a good amount of relief after starting after 10 to 15 days, and then after rehabilitation, he or she feels a lot better, more than 50% better after that day. So that is one of the thing which we can do in cases of those cases who don't want to get RFA done. One last question. When you do RFA of suprascapular nerve, do you prefer the conventional RFA or have you tried the pulse radiofrequency also?
I have very strong views about pulsed RF, and I'll tell you right away. I don't believe in pulsed RF. I feel it's a sham procedure because
Yeah,
most
same.
if you look, and this is my feeling based on the experience and the literature, a lot of literature would say, and you can look at it. There was an article published in 2019 by Steve Cohen, and it was based on जो हिंदी में कहावत होती है हमाम में सारे नंगे हैं. So it was Emperor's Clothes, and he looked at the evidence for pulsed RF for knee and different kinds of RFs for knee. And pulsed RF starts working around 2 to 4 weeks, lasts for 3 months. And you inject steroid with it, so you don't really know if it's the steroid which worked or the pulsed RF which works. Conventional RF works for, like, if you do it in spine, you get easily around 12 to 18 months. If you do it in peripheral joints and you do it the right way, you'll get around 6 to 12 months, which is better than 3 months, up to 3 months that you get with steroids. So for me, there's no comparison for pulsed RF versus conventional RF. I don't usually do pulsed RF because of all of this. Low duration of benefit. You inject a co-intervention in terms of steroid, so you don't know whether pulsed RF worked or the steroid worked, and the duration of relief is similar to steroid.
So we are out of questions now. So we had a very rapid fire.
Can I ask you one question?
Me, sir?
Yeah.
Yes, sir, please, sir, please.
So you mentioned the PRP that you do. Like, do you do it in all different stages of OA, or do you do it in only very specific glenohumeral osteoarthritic stages?
Sir, ideally, we should be doing in stage 1, 2, 3, up to 3 stages. But practically, if you see some old ladies or old gentlemen around 60, 70 age who have a very bad shoulder with a superior elevation of humeral head and all those changes are there, multiple rotator cuff tear are there. The patient is suffering from pain and he doesn't want to go for RFA. Then the best thing which I can do is that injecting PRP in the shoulder joint with the anterior approach or posterior approach. With this technique, after 10 days, I started with the rehab program, and in next 10 to 15 days, the patient always leaves, say that 50 to 60% patient pain relief is always there. So this is the thing which I have observed, and this is a very consistent thing which I have observed in these cases. So RFA is...
How long would that effect last for from the PRP that you give?
Sir, single sitting, I have observed the patient up to 3 months. After the patient usually don't come, you already seen in India, the patient, if they have got a good amount of relief, so they don't come back. So the patient is okay. They expect they can do their only basic functional activities like wearing clothes and having some food and combing hair. So they are comfortable with that thing. So this is the thing.
These are the patients who have failed steroid, or they don't want steroid because steroid
they have already failed. Most of them have already taken intra-articular steroid by posterior approach by some orthopedicians or some pain physicians. So they have already taken steroids. So RFA, if I say, I have done 3 to 4 cases only in last 5 years. The reason being is that most of the patients don't want to afford RFA for these things. So that is the biggest problem which I am facing, sir.
Yeah, no, that's true. So the people you have treated are mostly have rotator cuff arthropathy, and not the primary OA, but the rotator cuff arthropathy. It works really well for 3 months when they failed steroid. Well, that's a good thing.
Rotator cuff arthropathy, which will lead later on to arthritis also. That the shoulder joint is deformed, and all those things are there.
Yeah.
So, sir, thank you very much. Okay. It was a very great presentation for the rapid fire round of questions, and all the audience were asking questions and uploading of this presentation. So thank you very much, and we will be leading your lectures in near future also. So from Academy of Pain Physiatrists, I'm thanking you for your wonderful lecture. So thank you, sir, and good night, sir.
All righty. Thanks, everyone. You have a great evening. Bye-bye.
Bye, sir. Thank you, sir. Thank you, sir.